I'll preface my talk with a couple things. One, when you see me at events like this, I'm usually following around Peg, and the reason is because she's brilliant and smarter than me. And I don't remember if we were at the airport or on the plane or what, and we should probably switch our talks. I was like, okay, whatever you say. And as I was listening, she set up, and a lot of your questions, I will reinforce a lot of things that she said, but in slightly different ways from more of a medication point of view, so that was great. The other thing is I can give a talk to a bunch of scientists and I don't get very nervous. I get so nervous talking to you guys because everybody has such unique experiences, and I'm always like, I got this really good question last time, I want to tailor my talk to that. And then as we walked in, I got a big head last night because someone was like, oh, I heard one of your talks was like one of the most streamed ever last year. And I was like, I didn't know that. And I changed everything to try to tailor it. So then I was like, maybe I should put some of the stuff from last year in there. But so anyway, I changed, then I changed back, and I changed. So if there's some things that I screwed up in my transitions, just bear with me. I don't have any disclosures related to this talk. Some of the general things some thoughts, we've already talked about the fact that everybody is very different in HD, and that becomes even more important when talking about JoHD. Treatment is highly individualized, everyone's different. We do not have any disease-modifying therapies for HD at this point, so what we're focusing on today is symptom management. So the individualized treatment plans, what are the things that we're thinking about to try to individualize things? What other medications are you on? What other conditions do you have that this medication is going to help with, but it might make this worse? Things like that. If I get in your guys' way, you can't see, just like yell at me or throw something at me. And so previous experience with medication. So earlier when they say, what do you want to bring in? Obviously the pharmacist is going to say, bring in a med list, but also a timeline of your meds so we know what symptoms were occurring when you had this medication. What have you tried? How long did you try it? Things like that. And as I mentioned in there, treatment strategies are going to change throughout the course of the disease. This is a progressive disease, and we'll talk about some of those changes and how challenging they can make decisions when we're trying to control the symptoms as well as possible. And we're going to talk about some non-pharmacologic treatment measures as well. All right, so every time I've given this talk, I put this up here, and this is the big three in terms of the symptoms. And Peg already went over most of these: motor, psychiatric, and cognitive. So one of the changes that I wanted to implement is, what about sleep disturbances? What about pain? What about tics? What about rash? Obviously things that we all just heard about, but these are the questions that we're consistently getting asked about. There are always questions about motor and psychiatric symptoms and cognitive symptoms, but these other things, as Peg mentioned, this is such a great study. This is the study that she already went through, but it is such a simply elegant study that really gave us a lot of information about how patients with JoHD and their caregivers are feeling. So this is that web survey that Dr. Nicolas already brought up. And the things that she already mentioned was that sleep disturbances, tics, things like this that are not part of that big three triad of symptoms, these are the things that are having a big effect on the lives of patients and their caregivers. Okay, so what's the deal with, I think, yeah, so I have a Seinfeld. So what's the deal with these motor symptoms in HD and JoHD? Why do some patients with HD have so much chorea and others have stiffness? Will tetrabenazine help with motor symptoms other than chorea? What's the deal with medications to treat these movements? My doctor said it was helping me, but now she discontinued my tetrabenazine. What's the deal with that? We already talked about this progression pattern a little bit. So this is a typical adult onset progression pattern, where on the left-hand side you see chorea, and these are motor symptoms. So you have pre-symptomatic phase, you're just trucking along, you don't really have any symptoms. This kind of prodromal phase where maybe you're starting to notice some of these motor symptoms, and then they start to progress. This term, though, of motor symptoms is a very broad term. And I'm going to show you some new data that is helping us to think about treatment for motor symptoms. And the point of it is to make us think maybe motor symptoms shouldn't be thought of so broadly. Maybe we need to think about the specific motor symptoms that are evaluated in HD. The UHDRS is the motor scale that is used. So I've split this up into kind of the three components about what is known when we measure that. So all of these are on a scale of 0 to 4. You add them all up, and that's your total motor score. So you have the chorea in various parts of the body, the face, mouth, trunk, arms, and legs. Then we have these symptoms that we know about, or we have these scales that we know are measuring the slowing of the symptoms are more prominent in JoHD. So this is like the rigidity, the dystonia, the bradykinesia, and then we have all these other symptoms that, is this really measuring what Peg talked about as hyperkinetic, so more of the chorea, or are these measurements of hypokinetic symptoms? So like eye pursuits, when they're doing this to your kid or to you, or what exactly is that measuring? What about when we're doing tandem walking? You can imagine chorea would have a large effect on your gait and how well you walk, but you could also imagine that if you had a lot of rigidity in your legs, that would affect that. So is that part of the test more focused on slowing of symptoms or chorea? And we just don't really know. We've submitted papers and reviewers in the field, experts in the field. We will say, oh, this is a hypokinetic symptom. No, it's not. And so there is confusion about this. All right, so this is a pretty slide, but confusing. So and this is brand new data. We haven't published it yet. So what we did is we looked at enrolled. So this is from 15,000 patients, and it represents 50,000 visits. But these are all, each line represents one of the 31 components of the UHDRS that I just showed you. And to me, you can see basically two patterns. You see this starts out and then it goes up, and then you have this one where it goes up a little bit earlier and then trails off. The only ones that look like that, these are the 7 chorea subscales. This is everything else. So why is this important? If we know that one of these is bradykinesia or a hypokinetic symptom, and all of these other things are showing a pattern exactly like that, it is telling us maybe some of these other symptoms that are less well-defined are more indicative of the hypokinetic symptoms and not hyper. And the chorea symptoms are in a league of their own. So when you have someone who has a total motor score of 24, for example, and that is all based on 4s, 0 through 4, 4 being the worst, 4s on the chorea scale, but nothing in these symptoms, they're having more chorea. But if you also have someone who has a 24 or 30, and it's because they have higher scores on the dystonia and rigidity scale, they have the same exact motor score, but they may be experiencing very different symptoms. Why does that matter to a pharmacist when I'm trying to make treatment decisions or recommendations to the physicians? So Peg already went over this. Now we have dopamine, so that's that neurotransmitter that she was already talking about. That's over here. And let's just say, I messed up this, let's just say that this little blue part just stays here. So this is just normal. You just have a normal level of dopamine. And then as the disease progresses, you get higher levels of dopamine. So that's the general thought in HD. You get movements because you have more chorea than you should. And then as the disease progresses, you get less dopamine than you should. Above the line of normal, you get chorea. Below the line of normal is when you're starting to get more of the slowing of symptoms, so the shuffling gait, the stiffness in your arms, and things like that. Going back to this scale, where I'm telling you that the chorea has this unique pattern relative to everything else, if we now are conceptualizing all of the other components of that total motor score as possibly being caused by lower dopamine, And the only things that are being caused by higher dopamine are these chorea scales. That really makes us we need to pause and think, how are we treating this medication? Now, I want to point out that, especially around here, where a lot of people are having symptoms, these things are happening at the same time. So this presents an even bigger challenge for us, because if these symptoms are being caused by opposite ends of the spectrum in terms of dopamine, and our medications are meant to target either too much dopamine or not enough dopamine, but these things are happening at the same time, it gets very complicated. But what are the only FDA-approved medications for Huntington's disease? Anyone throw anything out? Tetrabenazine? There you go. End of the story. So the only FDA-approved medications are these VMAT2 inhibitors that are specifically designed to decrease release of dopamine in the brain. So if we go back, the only medications that are FDA approved are meant to focus on these medications, or on these symptoms. If they are specifically designed, how do these work? Okay, good. So we're going on to that. How do they work? I just told you that. So what happens to those other symptoms that are not chorea-based symptoms when you are decreasing the dopamine? You may very well be helping with the chorea, but it's possible, we don't know this yet, but it's possible that you could be worsening these other symptoms. When you consider that a patient is experiencing chorea and those slowing of symptoms simultaneously, but the only FDA-approved medication that you have is going to affect one of those and make the other one worse, we need to really monitor which symptoms are making the patient feel worse, which symptoms are really having the most negative impact on their day-to-day lives, so that we can specifically tailor our treatments to them. I already told you that. So if you have two patients, one person is here, the blue, or one is here, which of these two patients is going to have the most benefit from a VMAT2 inhibitor? Blue, who says blue? All right, anyone say red? Yeah, so this person they have more dopamine, so dropping that dopamine with a VMAT2 inhibitor, they might still be having these hypokinetic symptoms. I've made this to show my point, but these symptoms are still going to be occurring in concert with chorea, but chorea seems to be the most prevalent symptom, the most prominent, so they would get the most benefit, presumably, from tetrabenazine and chorea.
This chorea you're talking about, is that a natural chemical we have in our body?
Chorea is the actual symptom. Dopamine is the chemical that we have in our brain and body. That higher dopamine leads to chorea. Chorea is the dance-like movement that occurs in HD. Yeah. Okay, so just to talk about tetrabenazine a little bit, I'll go through this relatively quickly. If anyone has any questions, please interrupt, whatever. And again, this is not to say that VMAT2 inhibitors shouldn't be used for any. We know that they work. We know that a lot of people feel better when they take them. It's more a discussion of how long should we stay on this treatment? Should we consider decreasing the dose at certain points in time? It's really focusing on what's driving that total motor score. Tetrabenazine, sorry, did you have a question?
Yeah, it's maybe on your previous slide, but these drugs are not they're not impacting the rate of change of the striatum. They're
correct.
Really just impacting the...
Correct. This is nothing that I'm talking about is slowing the disease course. The way you would presumably slow the disease course is by slowing the rate of degeneration of the striatum. This is, as that striatum gets smaller, it throws all of these neurochemicals into imbalance, and this is how can we try to stay ahead of the curve, knowing that the striatum is getting smaller, knowing that these chemicals are changing, and knowing that our medications are going to have helpful and harmful effects as things progress in a certain way. So you need to titrate this up. That's really just for the sake of preventing side effects, the most notable being sedation, fatigue. We are guessing on what dose is best for people. We have patients we'll have 60-year-old women who are 100 pounds. who require huge doses, and we have 40-year-old men who are 6'6", 300 pounds, and they require tiny doses. We basically titrate to about 50 milligrams a day, taking it twice a day, and see how you feel. Trying to get a balance between how well are we controlling your chorea and how many side effects do you have. The balance is more in favor of side effects, we would drop the dose and see if we're still controlling symptoms. If you are off of the medication for more than a week, then you need to retitrate it just to avoid side effects. Tetrabenazine or Austedo is relatively new. I realized this morning that I had not updated my slides to reflect the fact that there is now an extended release version of Austedo, which is once daily. So this is referring to historical Austedo, which is the non-XR. So that is still dosed twice daily. You can titrate up to a dose at most of about 48 milligrams twice a day. Basically, the conversion here is it's about half the dose of tetrabenazine. So 12.5 milligrams tetrabenazine is equal to about 6 milligrams of Austedo. It's thought to have a slightly better side effect profile. That's one of the advantages of it, maybe a little bit longer half-life. And then valbenazine is dosed once daily. So think about smoking and smoking cessation. So if someone's smoking, one of the reasons that smoking can be so addictive is because you get these peaks and valleys. And so when you are trying to help someone to stop smoking, you maybe put a patch on them that kind of gives them a lower peak that lasts throughout the day. Same thing with valbenazine, where it's once a day, so you're not getting those peaks and valleys. So that is why it is thought to have fewer side effects, because it's a smoother, all-day control of the symptoms. Again, everybody is very different. It is not uncommon for someone to switch from tetrabenazine to valbenazine or do tetrabenazine. They're like, I feel worse on this. I have more fatigue. Like, okay, that's just how your body chemistry is. So these are just general statements about that. I have the conversion isn't exactly clear, but it comes in 40 milligrams and 80 milligrams. You can look at that if you'd like. So how do you decide between these? I think we've already talked about this. One of the things that we base a lot of our decisions on is insurance. So tetrabenazine is now generic. So a lot of insurance companies may prefer that because it's a little bit cheaper. The problem with that, though, is if you have Medicare, for example, or some commercial insurance, it may be that it covers 90% of the total cost. This is still an expensive medication, so that may end up being $100 a month, and the copay assistance programs for tetrabenazine specifically are not as robust as they once were because it's now generic. On the flip side, Austedo and Ingrezza are relatively new, so there are a lot of copay assistance programs for those medications. So if we have someone who maybe it gets approved for tetrabenazine, but it's still a $100 copay a month, it's not uncommon for us to switch to one of the brand name medications that are available for the sake of cost savings for the patient. Yeah.
We have to get our tetrabenazine through a specialty pharmacy.
Yep, almost all of these are only available through a specialty pharmacy. There are all sorts of specialty pharmacies. We have one at the University of Iowa, but they are very insurance dependent. Some insurance companies require you to fill through CVS specialty pharmacy or a Credo specialty pharmacy. So that is, in my opinion, an unfortunate thing just because it makes care a little bit more fragmented, because sometimes when we're making a decision about we want to start you on this medication, we just have to blindly send it somewhere, and we don't really know yet where it needs to go, and that can lead to delays in actually getting it.
It also, when we first started taking it, they filled it, sent it to our CVS.
Oh yeah.
But it didn't go to the pharmacy, it went to the front counter.
Yeah.
And so the pharmacy, we didn't receive it, and the pharmacy, and the specialty pharmacy was like, it was delivered.
Yeah.
And so we had to find it essentially.
Yeah.
And then once we did it, eventually we got it, and now comes directly to our home, but.
Yeah. Yeah, once it gets, because the companies have good patient assistance programs, they try to help with it. There are unfortunately situations though where because of insurance issues and things like that, it can be very difficult. Okay, so again, what works for one person isn't going to work for everyone. It's highly individualized. One of the things I didn't talk about with this is the risk of depression. So all of these medications are going to have a black box warning for causing depression. That is not, I'm a bad person to ask about this because we've written papers about the fact that this is not, we used enroll to show that people who were using tetrabenazine did not have a significantly higher risk of having depression. And when we look into the reasons why this black box warning came to be, it was because of a patient who completed suicide during the tetrabenazine clinical trial. From what we could gather from the FDA, there were a lot of social factors that led into that. But dopamine is also a medication that's targeted for depression. So pharmacologically, it makes sense that if you're decreasing dopamine, you could get more depressed. But it is not something that we see very frequently, if ever, clinically, where we have someone who starts tetrabenazine and or Austedo or Ingreza and they get significantly more depressed. It is still possible. We still warn everybody about it. But if you are well controlled with your depression, in our opinion, that is not, just because you have depression is not a reason to not take tetrabenazine if it is indicated. Or a VMAT2 inhibitor, I'm sorry. I've been doing HD stuff for 10 years, and I'm showing my age on this now because tetrabenazine was what we had when I started, so VMAT2 inhibitors. Okay, I think we've gone over this, so I'll skip over it for the sake of time. This is what I showed earlier. This was adult onset HD. But what about JoHD? It's basically the same course as Peg already discussed, just fast and furious. And so why that's important, so with the dopamine thing that I showed earlier, it is likely the same exact thing. So if you have, a lot of times when you read papers discussing the symptoms in JoHD, it's based on the time of diagnosis. So to your question earlier, it's based on diagnosis. That may have occurred, usually on average, like 5 years after symptom onset. As was already discussed, we mentioned tics. When you have a 6-year-old who does not have a genetic diagnosis of JoHD, they may not receive one for another 5 years because it is much more difficult to get that genetic testing and things like that. It is very possible that and again, Peg was very much correct that you may have ADHD. It does happen. But it is also important to consider, are those tics actually chorea? But it's just harder to parse out chorea as we think of it in the adult population versus a child. Similar with hyperactivity, a child who is just a little bit more fidgety and things like that. If they are still having this high level of dopamine, it's just a shorter period of time and it can burn out faster, it is worth noting, and you don't know, everyone is different, but it is worth noting that the tics, some of the hyperactivity and things like that are described prior to diagnosis may very well be part of the chorea that is being seen in those patients before they reach this point where they are reaching the hypokinetic symptom, and this kind of progresses throughout their lifetime. So, is there a way to treat those hypokinetic symptoms? There is very little research on this. This is a very difficult topic. And let me just say, so let me jump to this one. If you have less dopamine, so this is where it's really important, where I was saying you could still be having chorea-like symptoms and hypokinetic symptoms simultaneously. Because you might be thinking, we have L-DOPA, carbidopa-levodopa that we give patients with Parkinson's. That's just dopamine. If we have less dopamine, just give dopamine. Some of the side effects of L-DOPA and dopamine agonists can be psychosis, hallucinations, things like that. So it is not as clear-cut as, oh, we're more hypokinetic now, just give dopamine agonists. Because even as these motor symptoms progress in this fashion from hyper to hypo, we still have a consistent trajectory of worsening in the psychiatric and behavioral symptoms. So we need to be very considerate of, let's not just throw a bunch of dopamine at them, because that could make some of those other symptoms much worse. I'm not giving you a lot of solutions. We'll talk a little bit about how we think about this in a way that it can actually help with management. So amantadine is a medication that has been considered. The results are conflicting as to whether or not it provides significant benefit for the hypokinesis. There are actually some studies showing that it can be beneficial for the chorea in HD, but it has been reported as possibly beneficial for hypokinetic symptoms. People do use the L-DOPA, so the carbidopa-levodopa. Again, it's something that you need to monitor very closely to see how it's affecting the other symptoms of your disease to determine if you are receiving a net benefit or not. As Peg mentioned, you need to really decide or figure out which of those subscales of the UHDRS are driving these symptoms. If it's more rigidity, then some of these muscle relaxants like baclofen may provide more benefit in helping to loosen up those muscles, relieve some of that pain that can occur from having your muscles constantly tightened up. So CBD products is a question that comes up very frequently at these conferences and in clinic. Actually, Karsten Sabt is someone we know. He's a really nice person, really good clinician over in Germany. And we were actually unfamiliar with this paper for quite a while. But I will spare you having to read the abstract. The conclusion was basically that patients who were using CBD products did have a significant improvement in their dystonia symptoms. With the legalization of CBD products in several areas, so here are the things as a pharmacist that make me a little bit nervous about it. Do I think that for a JoHD person taking CBD is going to be harmful? No, not really. Now, that's a blanket statement. There are obviously situations where you need to be careful about its use. The things that make me a little bit more nervous are, like in Iowa, where it's still not legalized, just gaining access to it. Consistency of dosing. So if you are getting a THC or CBD product at a dispensary, and what you get month 1 versus month 2 may be different. So if you have really good control of some symptoms 1 month, and then the next month you don't, we don't have much control of that from like a pharmacological or from a pharmacy management point of view. So that's just a risk in terms of consistently getting the benefit that you want to see. Yeah?
Dr. Shultz, can you describe the difference, and hopefully I'm not jumping ahead, CBD versus THC and the content?
Yeah, so the CBD, again, the research on this in terms of mechanisms is still lacking, but the CBD, let's see, so that is the product that is thought to actually hit those cannabinoid receptors. THC is the more active ingredient in marijuana that is going to cause more of the pleasurable effects. Now, CBD is also implicated in this, but THC may be more to blame or more responsible for some of the appetite stimulation that can occur, which is also potentially a beneficial effect of THC and CBD products in JoHD patients who are losing weight and their appetite is suppressed. So yeah, that's not a great answer because there's still a lot that we don't know.
Do you recommend just CBD or do you recommend CBD and THC?
I think that
I recognize these are hard questions. But
no, I think that the CBD alone is good. That is still a very good product. So I think I would recommend starting with the CBD product only, just because you may get significant benefit from it without some of the negative side effects that come with THC use. That's what I would recommend, yeah.
Do you have to, so like in Texas CBD is legal, but with my girls being so young, or aren't being so young, how does that come into play with CPS or like cops getting involved? Or?
Yeah, I think so I'm not sure, I mean, everything state by state is so different.
Yeah.
In Iowa, and I don't know if you can get, I think you can if you're less than 18. Can you get those cards? Yeah.
And for kids, that's a great question.
I actually don't know.
You can, because in Iowa, one of the indications is seizures.
Yeah.
Pediatrics, yeah.
So up in Iowa, it says that FDA approved. Okay. So you're off with prescribed.
Okay.
It's probably.
You do need to go to a doctor. Don't just go to your local THC
Depends
shop.
on the state. So,
Okay.
for example, in Maryland where I practice, we're not allowed to tell you
Yeah.
go to it. Even though dispensaries are legal,
Yeah.
physicians can go to a dispensary to be product, like show something like that. Part of that is those aren't regulated, and there are a lot of different cannabinoids within cannabidiol, and so you don't know what mixture that you're getting or what the actual milligrams. So we prefer to prescribe antibiotics because we know exactly how much you're getting, and it does have its own side effects. Like it can affect the liver, it can affect with other medications, and so that way we're able to just have a better handle on it, and our hospital will carry down the formularies. Another problem you might run into is if it's not legal in your state, and it does have active, it is doing something for your child, and so now all of a sudden you take that away while you're trying to fix another problem.
And that's where you have to go to.
Through dispensaries, so you can, if it is indicated, you can get up to dialects. My recommendation is that's the way to go.
And that's the CBD form.
Yeah, but I also see Marinol is THC, that's what we use for transplantation.
That would be my Charlotte's Web for a little over years, but I didn't know that there was
Yeah, but
a one that it was trying.
Yeah, if we could get,
We get covered for epilepsy. If you're sort of doing don't have it, it's really tricky. So that's the
So my daughter is doing THC CBD, and it is for the pain. She did use Marinol. It was helpful, but a challenge we ran into that is the production of Marinol.
massively
it's-
on shortage.
Yes, it's very hard to get. I literally was buying it all around where I could get it, and they're running out and it's not being refilled. I called the manufacturer and had a conversation with them. So it's a good luck finding Marinol is what I would say, but the THC CBD has been very helpful to my daughter with the pain that she gets from the tightening of the muscles. She's on one pill in the morning that's half THC and half CBD, and we talked to the dispensary who helped us figure out what dosage to give her, and they did half and half because the CBD will help her stay more alert and less that high. I mean, I've never had any of these drugs, so I don't know. But so she's more alert and awake during the day, and it works great. She really is. She's with it. But at night, it's a lot less CBD, and it's so that she can sleep at night.
Yeah.
So
just to clarify, I go back to whatever my law is in Texas, I would just need to talk to a neurologist to see about getting
I would see if you could get a medical card so
Okay.
that if there was a situation where she had to give a urine test and it shows up positive for CBD or THC, they're like, why are you giving your child that it's a medical card, this is...
Yeah.
I would say too, so that though, I don't think it's covered, so that's something to think about too.
Right.
The Marinol was covered by our insurance. We are paying ourselves for that, and I do find it a little weird, though, even though it's approved and legal in the state of Iowa, you have to pay in cash. I don't know why. It's legal, but you have to pay in cash, so just know that too.
It's still federally illegal, so credit card companies and things like that.
Oh.
Process.
Okay. Thank you. I didn't know, but I do know that is challenging with travel. I was going to mention that.
So would a child under the age of 18 be able to get her a card online?
I don't know the state-specific answer to that.
Depending on the state.
Yeah.
And I don't know if this is just Iowa too, but so my daughter has a card, and then I have a separate card as her caregiver. But when I order the meds, I have to order them under her, but I can go pick them up. It's no issue. And I don't know if I just don't know how much is consistent across the states that have it.
He was on Marinol for a little while. He didn't like the way it made him feel, and then we didn't have to have any special card or anything. They filled it at CVS for us.
Because Marinol is FDA regulated.
Yeah.
So Marinol is not from a dispensary, that's from the pharmacy.
Now he uses like a cart, and he actually takes HHC, which has less chemicals, I think, in it, is what the H versus the T is. So if it's less processed or something, it's usually figure out, but it's his doctor approves it for him.
you have to see the physician or whoever is a consultant. That's part, so your doctor, even though you may be seeing somebody, that person can't write the letter. Typically, they want you to go and see and consult, because then they're gonna be giving you the amount and how much they're gonna recommend. Yes, you have to use a travel consultation with them.
That is a good question, Melissa, because they helped me, because there isn't any, it's not like a pharmacy and the pharmacist is determining how much you get, it's this person. I don't.
At the dispensary?
At the dispensary.
Right. Okay.
And so we met with this person who recommended these levels, and then he said, try these, give this some time, and then if you need to adjust, just tweak it by maybe half a pill. See how that changes things. But it's really that you're on your own somewhat. But I thought that the person we worked with was giving us some good guidance.
Experience. They typically are pretty experienced, at least the ones that I talk to.
Yeah.
Tinctures?
Pardon me?
They do tinctures, like liquid?
No, she's a pill. It's a pill. I think
Yeah, they gave them their little.
yeah.
This is
Yeah, North Carolina and all that stuff is, we don't have dispensaries. We don't have any of that stuff. So that's why I've just been ordering for years that Charlotte's Wow, because that seemed like a brand that I knew something about. So that's, I use the liquid for her for that. Whether it helps or not, but.
I am very happy to talk to people more about this afterwards, if I know, but I also, because Dawn has a lot of information on this, I want to make sure she has time. All right, so most common psychiatric symptoms in HD, depression, anxiety, irritability, or there's a lot that can happen, but these are some of the big ones that we talk about. So depression is very common. One of the things that's important to note about is that the depression is usually most prominent around the time of diagnosis. So this is the just disease course down here, and this is depression. Again, this is from Enroll, so this is based on a lot of people. But it's interesting because it's not progressively getting worse. It's something that very commonly peaks, and this is oftentimes a consequence of cognition. So how much insight does the patient have into their current situation? At the time of diagnosis, where things are happening, like maybe you're not able to drive, you're losing some autonomy, and you still have insight into that is upsetting. Later on, you may not have as much insight into the fact that these things are happening to you, and apathy is a big part of the disease. You're more empathetic. It's like, okay, well, that's fine, this is happening, whatever. The reason I bring this up from a medication point of view is this is one of those things I was discussing in the panel. I'm not saying you should stop your antidepressants, but this is just something where you might consider having a discussion with your provider about whether or not you or your loved one are in a position where the antidepressant medications are still providing benefit to justify the interactions and side effects that they could cause. So the treatment is basically the same as it would be for someone who doesn't have HD. The SSRIs that Peg talked about, SNRIs, I listed some of those here. How do you choose? You want to choose based on those things we talked about earlier. What other comorbid conditions do you have? What other medications are you taking? Making things like that. What are the side effect profiles of these different medications? All of these medications are very similar but very different. If one does not work for somebody, it doesn't mean that another one will not work for you. So one of the things I wanted to highlight is that for these antidepressants, it can take at least 4 to 6 weeks for them to reach their full effect. So it's not uncommon for someone to start a medication and then call back a week or 2 later, and I don't feel any better. And you have to say, okay, let's wait a couple more weeks if you're able to, see if let's give it enough time to do what it needs to do. If you're still not seeing improvements at that time, let's consider a different medication. So other medications can be added if you do reach that time, and still, maybe it helped a little bit, maybe you've tried 2 or 3, and this one is helping a little bit, but you're still not happy with the level of control you're getting of your depression. Things like bupropion, aripiprazole is an antipsychotic that can be used at lower doses. And benzodiazepines are something that can also be added. I know we're running out of time, but benzodiazepines are an interesting medication in HD because they have the potential in some patients to provide benefit for various different aspects of the disease, whether that be sleep initiation, anxiety, potentially some of the movement symptoms, including the hypokinetic symptoms that we already talked about. They should not be used with alcohol. They can have additive effects. So it's not, I'm making these sound like a really great drug. They do still come with side effects like causing fatigue, there are interactions. There is a risk of dependency with these medications. So they can be very useful, but they need to be monitored very closely. So the irritability, I'm already over time. So Peg already went over a lot of these things. We already talked about the fact that some of these antipsychotics can be very beneficial for the irritability symptoms, but we need to be very considerate, going back to the motor discussion that we talked about. So the VMAT2 inhibitors are preventing the release of dopamine in the brain, whereas these antipsychotics are still affecting dopamine, but they're doing it at the receptor level. And so they can still have the same effects on decreasing the effect of dopamine. So going back to patients with JoHD, you really need to think about how could this impact those hypokinetic symptoms that they may be experiencing. This is a situation where we want to be more mindful of which antipsychotic we would be adding on, because how each medication interacts with that receptor is different. Some of them are much more attracted to that receptor, and that can make them more prone to blocking the dopamine effects. Some of them interact with that receptor differently, and they may have a lower chance of causing some of those hypokinetic symptoms. Again, balancing how well they can control the irritability symptoms with how they may negatively affect some of the motor symptoms is something that should be considered. So we talked about that. I mentioned this in the panel. We recently published this paper where memantine, a medication used for Alzheimer's, it didn't provide any benefit, unfortunately, for patients with Huntington's. We still do not have any medications that are known to provide any benefit for the cognitive symptoms of HD. Sleep disturbances. I will go through this quickly, but we are really good at giving medications that put people to sleep, but we're not very good at being able to keep them asleep or regulate the sleep cycle. This is a paper showing that melatonin has been found to be decreased in the brain of patients with Huntington's disease. And so melatonin, just over the counter, can be a very powerful medication for patients with HD to help with sleep. One of the other things is that generally if you reach a dose of like 10 milligrams, you're not going to get any more benefit. Some people do great with 1 to 5 milligrams. So if you give somebody 2.5 milligrams of melatonin, they fall asleep, and then they wake up 4 hours later and you wanted to give them an additional 2.5 milligrams of melatonin, that's perfectly fine. That would be okay. You're still within a very reasonable dose. This doesn't work for everybody. Some of the other treatment options that we would consider is trazodone. That was originally marketed as an antidepressant. So again, the discussion of should you be talking with your local pharmacist and everything? Yes, you absolutely should. I know I'm going very fast. I'm very happy to talk about this with anyone else. You want to look at things like poor sleep hygiene, caffeine intake. You want to look at other things that are going on in that patient's life. Changes in sleep regulation and cycle can be affected by depression, anxiety. Are they having breakthrough anxiety? Would this be a situation where a benzodiazepine that I mentioned would be beneficial to help with sleep? And also troubles going to sleep because you're having anxiety. So the pain and itchiness, Peg went over this. Oftentimes that is more of a neuropathic type symptom where the signaling from the brain is just being disrupted, and that can cause problems. So some of the medications that we have used pretty effectively is gabapentin. Sometimes you have to go to relatively high doses, but medications that you would use for any type of neuropathy, like diabetic neuropathy, like duloxetine, which is an antidepressant, venlafaxine. So again, this may be an opportunity where you could, if someone's already being treated for their depression, perhaps you could switch them to an antidepressant that would also help with neuropathic pain. Itchiness, sometimes steroidal cream can help, even though there is not a rash associated with it. Sometimes just ointments in general. People have said, this is just anecdotal, but they've said that helps. So I had a patient case, but I'm not going to go through it for the sake of time. I have no reason to show this picture except for you gave me an opportunity. So there's my kids.